Good morning. Welcome to another edition of McMaster Perspective. Our guest today is Professor Jean-Claude Tardif, and the topic will be colchicine in coronary artery disease. Professor Tardif, maybe a few words about yourself to start with.
Yeah, thank you for having me. My name is Jean-Claude Tardif. I'm a cardiologist and the director of the Montreal Heart Institute Research Center, and I hold the Canada Research Chair in Precision Medicine and the University of Montreal Endowed Chair in Atherosclerosis.
Well, that sounds very impressive. Colchicine in Montreal seems to have a history. I remember a study in COVID coming out of Montreal, I believe, and colchicine. But let's concentrate on coronary artery disease. Why should it work? What's the theoretical basis here?
Yes, well, there have been a large number of studies, both preclinical and clinical, that have shown the central role of inflammation in atherosclerosis, including coronary artery disease. So atherosclerosis actually is an inflammatory disease. The arterial wall is filled with different cell types, monocyte macrophages, lymphocytes, and neutrophils, as well as several cytokines and chemokines. And there have been studies showing that when you reduce inflammation preclinically, you affect favorably atherosclerosis. And then there have been a few large studies that have shown that when you reduce inflammation by different ways, by the way, in patients with coronary artery disease, you improve cardiovascular outcomes.
All right. Well, I guess you could always, when you were talking about anti-inflammatory influences, aspirin would be the. I'm sorry if I'm saying something completely wrong, but aspirin has a lot of anti-inflammatory and influencing your cytokines things. But let's talk about colchicine. It caught my eye.
Well, let me get back to what you just said so that people understand. The usual dosage of 80 milligrams per day that we use with aspirin, it has no really significant anti-inflammatory effect. And the second thing is, I was not going to go into all the molecular aspects, but it's not just any anti-inflammatory agent that is going to improve cardiovascular outcomes. It appears that the IL-1/IL-6 pathway is probably one of the most important in the pathophysiology of atherosclerosis. And so inhibiting COX-1 with aspirin would not be the significant pathway to use to reduce cardiovascular events in patients with coronary artery disease.
Well, thank you for clarifying this. I probably shouldn't venture to unknown to me waters, but let's try to summarize your own work, if you don't mind. I think it starts a good few years ago.
Sure. So there have been two large studies, randomized trials, with low-dose colchicine. When I say low dose, it means 0.5 milligrams once per day, that have shown that when you reduce inflammation with low-dose colchicine, you improve cardiovascular outcomes. So the two large studies are called COLCUT, the colchicine cardiovascular outcomes trial that we led, and I can say a few words about that. And the second one is LODOCO2, the low-dose colchicine 2 study that was conducted in Australia and the Netherlands. Both studies were published in New England Journal of Medicine. COLCUT, our study, was a study of 4,745 patients, and the LODOCO2 study was a study of 5,500 patients. Our study, COLCUT, again, a double-blinded, randomized study of patients that had suffered a myocardial infarction within the previous 30 days. And again, these patients were receiving all the right drugs you can imagine after a myocardial infarction, 2 antiplatelet agents in 99% of patients, and a statin in 99% of patients. And then patients were randomized to receiving low-dose colchicine 0.5 milligrams once per day or placebo. And the addition of low-dose colchicine to standard of care compared to placebo reduced the primary endpoint incidence by 23%. The primary endpoint was the composite of cardiovascular death, myocardial infarction, stroke, and urgent hospitalization requiring coronary vascularization. And the second study, LODOCO-2, was in patients with stable chronic coronary artery disease, and the primary endpoint of that study was reduced by 31% by low-dose colchicine. So very consistent results from two large trials.
Not only consistent, but also quite large, because you are cutting the risk by about a quarter, which is as good as any other medication for coronary artery disease, which I know. And you just summarized that it works both in acute setting. I believe in your study it was started within 3 days. And
so it was started within 30 days, but we did perform an additional subgroup analysis where we saw that patients indeed in which we started colchicine within 3 days got an even better result.
Right. So very impressive results. Yet when I see patients in coronary artery disease in Hamilton, which is the epicenter of evidence-based medicine, I don't see much colchicine being used. Or what's the uptake of this medication in this condition in your experience?
So it varies from region to region and from country to country. In Montreal, we do use it to a fair amount. There are countries where it is being used quite a bit, like Australia. Colchicine is used fairly widely. What is exciting, more recently, the FDA, the U.S. Food and Drug Administration, has approved low-dose colchicine for prevention of ischemic events with a fairly large indication. So gradually, I think uptake will improve. I think it's probably a similar story to what we observed 30 years ago with statins, where after one large study, there was not a sea change of intensive use of high-dose statins, and it took a couple of studies to convince people that this is true. There is another component to the story, or a reason for why the uptake may be a bit slower than hoped. Unlike statins or PCSK9 inhibitors or SGLT2 inhibitors, where large pharma, the big pharma industry, is pouring hundreds of millions of dollars of marketing into this. Obviously, colchicine, with its cost of 50 cents a day, is actually more of a threat to big pharma than anything else. So there is not a lot of push behind of this, and that's why discussions like this and more open dialogue hopefully will change positions and minds. Certainly, we're quite thrilled that within the last year, colchicine has entered the European guidelines, the American guidelines, and again approved by the FDA. So I think over time, I have little doubt that one day we will see that the majority of patients with coronary artery disease will be treated with inflammation reduction therapy.
As of today, if you had your patient with a post-acute myocardial infarction coming out from acute admission to Montreal Heart Institute, how many of them would be getting colchicine?
Probably now about 40%.
Okay. Why? Why so little?
Well, for the reasons I mentioned, it is not being pushed systematically.
Okay.
If you go to the next meeting of the American College of Cardiology, probably when you go to your hotel room, there'll be a picture of a PCS. I'm not making this up. A picture of a PCSK9 inhibitor with the name of the company and the name of the drug on your key, on your room to your hotel, on the key to your hotel room.
I understand.
Whereas there's no such thing for a pill that costs 50 cents.
All right. Well,
and so I think there needs to be more dialogue, and I have little doubt. Now, obviously, we see several companies developing new anti-inflammatory agents.
Right.
And paradoxically, when they're all there and their drug are shown to work, then
Right.
physicians are more likely to react. But I
Okay.
think things will
Gotcha.
change over time.
Maybe colchicine will be an alternative to tocilizumab, for example. You mentioned IL-6. I'm joking at the moment.
Well, there's one pill that is orally administered and costs 50 cents a day. So I hope that
Right,
people will
right,
come to
right,
realize that
right.
that it makes a lot of sense to use it.
Are you aware of any ongoing research with colchicine in coronary artery disease?
Oh, sure. There are several studies. Actually, this year there'll be the large CONVINCE trial from the UK that will be reported. This is a study of low-dose colchicine in patients after stroke. But going back to coronary artery disease, there is also a large study after myocardial infarction, STEMIs, that is called the CLEAR study, that is conducted out of McMaster. And we are also running a large study of 10,000 patients in primary prevention. We're very excited about this. The COLCUT T2D trial, 10,000 patients with type 2 diabetes in primary prevention, that is, patients should not have suffered a myocardial infarction in the past, where we are testing the role of inflammation reduction in type 2 diabetes specifically.
Well, that is quite something. Our interview is directed to frontline clinicians. Is there any experience you could share with them in terms of what to look for in terms of tolerance or side effects if they decide to start this low-dose colchicine?
Yes, thank you for the question, because often when people think of colchicine, they think about gastrointestinal symptoms and specifically diarrhea. So a couple of things here. We're talking about the use of colchicine 0.5 milligrams per day, not higher doses. A couple of points before I talk specifically about tolerability. Sometimes I hear, well, what's the difference between 0.5 and the usual 0.6 dose? Without being too facetious, the answer is 0.1 milligrams. But more than that, when people say, oh, it makes no difference, well, I'm old enough to have used quite a bit of digoxin. And you know that there's a big difference, let's say in old people, between using 0.125 and 0.0625. So that's a difference less than 0.1. And it can make a world of difference to tolerability particularly in old people. So getting back to tolerability of low-dose colchicine. So if you go back to our own New England Journal paper reporting COLCUT, there was not even a significant increase in the incidence of diarrhea with low-dose colchicine compared to placebo in that study. So that was even, surprising to us. The drug is, fairly well tolerated. If you go to low-dose CO2, where there was a period where everyone before being randomized received colchicine, which was not the case in our study, you perhaps can expect 7-8% of people that might have some GI-related side effects. There are some very practical tips for clinicians. We're in no hurry of starting, and that therapy and obtaining maximal effect. So if someone has a side effect, maybe loose stools or diarrhea, you can give a holiday of a few days and restart with colchicine every other day for 2 weeks. And in my experience, the majority of patients then will tolerate low-dose colchicine very well. So that's one way of doing things. I personally, not uncommonly, would explain all of that to patients and will say, we're in no hurry. So let's start from the get-go with low-dose colchicine 0.5 every other day. You're going to get used to it for a week or two. And then if you tolerate well, go to a full pill every day, 0.5 milligrams per day. So that's the kind, and realizing that some patients might not tolerate it. And I tell these patients, well, if you don't tolerate it, let's just stop it. And, we will have seen, but the vast majority of patients will tolerate it. The other thing I would tell clinicians, to get to your question, there's a disease we don't see that often in Canada that's called FMF, familial Mediterranean fever that is quite common in, in patients living in countries around the Mediterranean Sea. And these patients are treated for life with colchicine, not with 0.5, not with 0.6, but with 1.8 milligrams per day for life. And so that drug is actually better tolerated than people say. And I would say test it in your patient, not for every, the patient, for the clinicians. Patients who complain of polypharmacy, oh, doc, I'm taking too many pills. Well, that's not the patient, the patient's taking an antiplatelet agent, a high-dose statin, different. So the patient who complains about taking too many drugs, probably not wise to start colchicine. But the patient that is truly concerned, saying, doctor, I'm concerned of suffering a stroke, of suffering, well, that patient, you say, well, there was a large reduction in the rate of strokes with colchicine in cold cut. So, and in meta-analyses as well.
Well, there is very few interventions which cut quarter of your risk. So the higher your risk is, the more benefit you have. And in today's medicine, we make decision together with the patient. So it's an important information to the patient. Professor Tardif, I'm very grateful for it. It's puzzling to me, why is it not uptaken more than it is, but I guess our interview will probably help few people to avoid heart attack or strokes down the road. I'm very grateful for your time. Thank you.
Thank you so much.